السلام عليكم. كل سنة وانتم طيبين والجمعة مباركة عليكم جميعا، وأنا اتشرفت بأن أكون معاكم وبشكر الدكتور أشرف على على تحت الفرصة، والدكتور طارق إن هو جمعنا على الخير دايما. ودكتور أشرف هو الحقيقة إحنا كلاس ميت يعني من فترة مش طويلة قوي، يعني 40 سنة تقريبا. بس هو الدكتور أشرف زي ما هو بنفس الشباب والهمة بتاعته، ربنا يبارك فيكم. التايتل بتاع البرزنتيشن النهارده على الكوروناري ريفاسكولايزيشن ان دايابيتيك بيشنت. الحقيقه الدايابيتس، البريفالنس اوف دايابيتس سواء في مصر او في السعوديه، البريفالنس دايابيتس في البوبوليشن is around 20 to 25%. The same problem في مصر وفي السعوديه النسيم. There's one registry في Saudi Arabia almost 10 years back about the prevalence of diabetes in acute coronary syndrome, space registry, that shows that the prevalence of diabetes on those patients who present with acute coronary syndrome is about 65%. الحقيقة احنا يعني تقريبا من كل 10 مرضى بنشوف 6 أو 7 منهم diabetic patients. والdiabetes carry a increased risk of cardiovascular event 2 to 4 folds mortality risk because of diabetes. We are considering that diabetes is a coronary heart disease risk equivalent, and it is a continuum. Diabetes is a continuum that they are not all the same. Yani just starting from pre-diabetic diabetes without complication or complicated diabetes. So it is a real continuum that interlace also with the continuum of cardiovascular disease, from the asymptomatic coronary artery disease to stable ischemic heart disease to unstable angina, non-ischemic and ischemic. So there is some interlace between the two continuum, and the higher the risk from both sides, you have to think in different way how to handle those patients. The pattern of coronary artery disease in diabetic patients, we all know and we all see it: small caliber vessel, diffuse nature of the disease, extensive disease. Most of them, they have multi-vessel disease. So the decision will be very tough and difficult because of this nature of the disease. So in reality, those patients who are eligible for revascularization from beginning, either by surgery or BCI, they are not all the patients. Many of the patients, they are not eligible for revascularization because of the pattern of diffuse disease itself, that make it not suitable for grafting, not suitable for stenting, and only for medical treatment. And I will show you that the medical treatment actually work, and we have to think about medical treatment before thinking about revascularization. Now, when the clock start ticking actually almost 10 years before the onset of hyperglycemia or discovery of hyperglycemia. That's why most of the treatment of hyperglycemia alone does not make an impact on reduction of cardiovascular mortality. For a long time, we are adding statin to those diabetic patients to decrease the risk, and some data about the metformin as well. And we have some new group of medications that decrease the cardiovascular risk, and we are targeting more hardly the LDL for those patients to decrease the cardiovascular risk. However, controlling hyperglycemia by itself alone does not have too much impact alone on the reduction of cardiovascular mortality, because it's the macrovascular complication start with the insulin resistance. And unfortunately, the insulin resistance is associated with multiple cardiovascular risk factors. You found a patient in the age between 40 and 60, and they have diabetes, they have hypertension, they have obesity, and they have some hyperuricemia. It's a multiple risk factors. The risk of revascularization itself with diabetes as well is higher, either surgery or BCI. If you found a patient in the cath lab with a blood sugar of 400, you have to be careful, because this is alarming about the acute event, the in-hospital outcome of this patient. The same for the surgeon as well. They are have data about the correlation between the post-operative morbidity, post-CABG, and the hemoglobin A1C. And many of the anesthesia, they want actually in a stable patient to postpone the case until they control the hemoglobin A1C. Now we have to think, number one, about medical treatment. And the medical treatment actually work. And we have a very good, large randomized trial, the ischemia trial, that actually enrolled 5,000 patients. And this trial was funded by institutions, not funded by companies, and in 38 centers all over the world, with a median follow-up of 3.2, and they addressed stable patient with moderate ischemia, and with a good ejection fraction, with normal ejection fraction, stable patient, Canadian class 1 or 2 with moderate ischemia. They do blind CT angio. Dr. Ahmed show us one. This is another indication as well. CT angio just to rule out left main or normal coronary, and then randomize the patient into group for revascularization directly plus optimal medical treatment, and the other one no case. So the randomization done before coronary angiography. That is the lesson that the message that we took from this important trial, that those patients with stable ischemic heart disease and moderate to severe ischemia, an initial invasive strategy did not reduce the risk of primary endpoint of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitation from cardiac arrest compared with conservative strategy. So the message is, if you have a patient with angina class 1 or 2, and he has moderate ischemia, and you out left main for him, then the medical treatment will work, and there is no need for revascularization unless the symptoms was not controlled by the medical treatment, which happen in most of the cases, in many of the cases, on the medical arm. Now there is some data, old data from the COURAGE trial giving the same message. However, we have to be just careful that this applies only for stable ischemic heart disease, not for ACS. Not for ACS. The acute coronary syndrome patients, they are different group and different outcome. There's one study, I think it's a complete trial, address those patients who present with acute MI. You do the culprit lesion, of MI, and then randomize the patient to medical treatment or intervention for the non-culprit, and it is complete failure for medical treatment on those patients. You have to revascularize the non-culprit vessels in the patient with STEMI in a staged procedure, either in hospital or another hospital admission. So stable ischemic heart disease, medical treatment work. ACS, you have to revascularize. Now there is a group of medication, statin, the PCSK9 inhibitors now is added. Also, there's some trials in high-risk patients that will add to the decrease the cardiovascular risk. You have two groups of anti-diabetic medication as well that start to have class 2B indication. And the antiplatelet are for either aspirin or clopidogrel only for secondary prevention. Primary prevention, you don't use it. So aspirin, even in diabetic patients for primary prevention, is a very gray zone, but it's not. There is no strong data to support its use in primary prevention. This debate is a long debate. If we say, okay, after medical treatment, what to do, BCI or surgery, at the end, surgery win. The surgeon win. The surgeon win by this trial, which is a freedom trial. It is actually a trial that is only diabetic patients. They enroll 1,900 patients, diabetic patient, and the inclusion criteria were multi-vessel disease with a stenosis of 70% in major epicardial vessel, involving at least two separate territories, two vessels, so 2 or 3 vessel disease with diabetes without left main, and they found that at the end, in 5 years follow-up, all-cause mortality was less in cardiac with CABG. They are, if I did not, if I remember well, it's almost 26% in the BCI group mortality, while it is 18% in the cardiac surgery. However, there is some late catch up on in follow up 8 years. There's some late catch up because of the graft occlusion, so 8 years. And the other point as well in this trial that the cardiovascular mortality was not statistically different. The difference was in all-cause mortality. However, this trial put the surgery for multi-vessel disease in diabetic patient, if it is feasible, give it an upper hand. Now, the EXIT trial is addressing those patients with left main and intermediate complexity of coronary artery disease. 30% of those patients have diabetic. A subgroup analysis of this trial shows that diabetes has no interaction with the result of the trial, which actually shows that the composite endpoint of the stroke MI was not significant difference between BCI and the CABG among those patients. So it's a very astonishing that if patient has a left main disease plus intermediate complexity, the BCI still can work, and you found the reflection of this on the guidelines. So it's a dilemma. At the end, surgery, surgery in multi-vessel disease in diabetic patient, if it is feasible, it is better than BCI. The problem with surgery is always there is a higher risk of stroke with surgery, while there is a higher risk of repeated revascularization with BCI. But the overall balance is going toward this CABG for patients with multi-vessel disease in diabetes. We are talking about multi-vessel disease, which is two or more, 2 or 3. But single vessel will be it's mostly for medical treatment or BCI. Also, if the LED is not involved, so RCA plus CERC, for example, this is for medical treatment or BCI according to the symptoms. Now, this figure from the last guidelines, which is this published this year, I just want to share with you that in stable ischemic heart disease, we are doing intervention for 1 or 2 reasons. Either we need to improve survival, or you need to improve symptoms. That means all of these patients, they should start with medical treatment. If you improve the symptoms improved, then you will go for triage of patient. You need to rule out high risk anatomy, which is left main or multi-vessel disease. However, if the symptom did not improve, then the revascularization is indicated, even if single vessel disease or double vessel, not including the LED. Now, if angina on refractory angina medical treatment, medical therapy did not improve, you will see for coronary angio's, and if left main, the left main is going on this angle. You see that most the green is for surgery or heart team. BCI only 2A in case of significant left main with moderate complexity. That is to get the recommendation, you get it from the Excel trial. Now, if there is no left main, they will go for multi-vessel disease, and the second will be what is the ejection fraction. If the ejection fraction actually is low, you will also go for surgery. If the ejection fraction is normal, then you will go for either surgery or BCI. I will show the conclusion of this complex diagram, that this is the guidelines. In patients with diabetes and multi-vessel with the involvement of the LED who are appropriate candidates for CABG with LIMA to LED is recommended. It's important that you use LIMA during the surgery, because the venous graft to LED does not, the result is probably is far beyond using LIMA on those patients. This is the only class 1 indication. Now, in patients with diabetes who have multi-vessel disease, amenable to BCI and indication for revascularization are poor candidates for surgery. If they are not good for surgery, then you go back to BCI with a class 2, 2A. Now, in patients with diabetes who have left main stenosis and low or intermediate complexity in the rest of coronary anatomy, BCI may be considered as an alternative to CABG to reduce major adverse cardiac event, which is class 2B, which is the XL drive. So this is now for multivessel is clear that surgery is better if it is feasible. You can use, you can go for BCI if surgery is not feasible. However, now the decision is very complex rather than this. The decision is actually need heart team. That most of the, in spite of, for example, of this freedom trial, some survey actually around 50,000 in USA, 50,000 patient was surveyed after the freedom publication of freedom, and they found still 60% going for PCI, not for surgery. And in reality, on our heart team, most of the heart team, you will find many compelling factors to direct you to either one. And in many cases, the patient will be declined by the surgeon himself. The diffuse nature of the disease, the small caliber, make those patients most of them are not suitable for surgery, and you can just go for BCI for the proximal lesions to help it, while the surgeon will not be able to put his graft distally because of the diffuse nature of the disease. The heart team approach is class 1, and actually this is in everywhere now, in any center you have, in any multivessel disease, Tariq know, and we are all multivessel disease in our center. We are actually we are not doing ad hoc PCI for them. We are doing a heart team for them to take the decision together. And one important thing that is, we have to be very clear with our patient as well, that patient preference is important. If he decide, you have to go after the heart team and tell the patient the whole truth, the whole discussion, and the pros and the cons of everything. Let him share with you the decision, and this is his right, and this is what we are doing in our center. I'd like to thank you for your time. جزاكم الله خير وشكرا جزيلا. دي بعض الصور الحلوه من حي، لكن طبعا مصر احلى كتير يعني. شكرا جزيلا.